everybody. I guess when Tony first asked me to present some data or make the presentation in this roundtable about lower respiratory tract infection, the idea or the hope was that we could present some data on our program. And early on, I told Pedro that we don't yet have the data. We're currently running our pivotal phase 3 study. It's a large efficacy study in preterm infants. So I thought of taking a different route, which was in the context of the discussion in lower respiratory tract infection, make some reflections around medically attended lower respiratory tract infection, medically attended acute respiratory infection without the lower infection component, and thinking a little bit about burden of disease. And this, to some extent, in the context of the view of the clinical development inside of the industry, and also looking at, as we reach later phases of different programs, how we might be thinking of all of this. And it was very interesting during the last 2 days to see that the slides that I have put together, the different sessions that we have had so far, touched upon several of the points that I had illustrated, or they illustrate what I had put together. So I'm going to run through those aspects, and it's really interesting to see how they really support the rationale as how we move forward as a community looking at prophylaxis of RSV. So I'll leave the teaser. As I said, although we're not going to present the data, we're currently running this large efficacy study, safety and efficacy study with Regen2222, which is a fully human monoclonal antibody directed against the F protein, prefusion. It does have high binding affinity and potency. It's a conserved epitope. We have checked it across various strains, current and past strains of RSV. And we're currently evaluating efficacy through the use of 1 or 2 doses across the entire season. It's a multi-season study. We began the study in 2015. We're going out to the second Northern Hemisphere season in the study. We have been in the Southern Hemisphere during this winter. And hopefully, a year from now, we're going to be able to share the data. So when thinking about burden of disease and thinking about what measures really translate the full burden of disease, I guess these are all aspects that are quite obvious to the audience. And in the last couple of days, we have been really focusing in severity of disease when we look at lower respiratory tract infection. And of course, when we think about severity of disease and lower respiratory tract infection, we're of course trying to link this to the healthcare utilization and to the health economics aspect of how one can approach prevention, and therefore also from the standpoint of licensing these interventions and also having them recommended is towards what really makes sense in terms of what is the value proposition in terms of you have now an additional intervention within the healthcare system and within a very busy vaccination, if you will, or immunization calendar, and how do you go about justifying the use of these products. And we now, I think it's well established that hospitalization as a primary endpoint or the sole endpoint for our efficacy trials in regards to prevention of RSV has been put a little bit aside as in one end. There's a lot of discussions around variability of what are the criteria that you use to hospitalize a child in different countries, in different settings, but also in the changes that have occurred in the health systems across different countries. So there seems to be a consensus now that we should be looking more towards medically attended lower respiratory tract infections as a very important endpoint that addresses also the concerns about the health economic aspects behind recommendation of these interventions. And then we fall into the first set of discussion that was clearly covered yesterday about how is it that we define a lower respiratory tract infection, and how easy is this to be done in established standardized settings. But how do you do this when you go towards global efficacy trials where you're going to over 100 sites, over 200 sites, and you need to standardize the criteria that you're going to be using? And then there are several definitions out there, and how is it that we come to a common ground, or will we ever get to a common ground of using the same classification? Then there are also discussions around, should we use lower respiratory tract infection as a primary endpoint or as a secondary endpoint in our efficacy studies as we reach phase 3? And this really relates to the fact that the interpretation, and as Janet was mentioning yesterday, things that seem easy to be analyzed and standardized in certain settings, when you really reach out the field, become very difficult. And perhaps if you use just the definition of medically attended as a primary endpoint, leaving the lower respiratory tract infection as a secondary endpoint, it might make it easier to allow your numbers in powering your studies. But there is also the aspect of collecting this information. And we did go about discussing pulse oximetry, and we did go about talking about chest indrawing and how easy it is or how not easy it is. And these are things that we're all thinking about as we look into our programs, and we should be looking at them as we move forward. So looking in a different way, we have mainly been focusing so now our discussions towards the medically attended spectrum of analyzing RSV within the context of our development plans. And we can see towards that extremity here that any acute respiratory infection, something that for now has been left aside. And Tony very well touched the point yesterday that in order to only using antibodies to reach sufficient antibody levels in the upper respiratory tract is something that's probably very difficult. And perhaps given the fact that we started development overall against RSV with monoclonal antibodies, this is something that's sitting aside, and I'll come back to it a little bit later, but perhaps this is one of the reasons where it's still sitting aside, and also the perception that, well, if you prevent acute respiratory infection but it has no significant impact in the health system, is it really worth it? And we also had a very interesting yesterday roundtable about wheezing and asthma. And this is something that internally at Regeneron, we have been thinking about it, and how is it that we insert it in the clinical development plan in a way that it could be acceptable for recommendation bodies, that it might be acceptable for agencies. And I was very pleased to hear two comments which really align to what we have been thinking. The first one from Renato Stein, when he says, we have to be very humble. RSV is just one of the components in this very complex theme. And therefore, it's very difficult for us to navigate through and establish how is it that we can effectively measure wheezing in these young infants who developed RSV early in life. And then I believe it was Ruth Karen who also stood up and made the question, what is it that we want in the end? Given the different phenotypes of children, those who are going to have asthma, or those who are just going to have wheezing until they're school age, what is it that we really want to prevent? And I guess as the evolution of the different interventions move forward towards later phases of development, we should all be thinking of that. And I'm definitely, like others, very curious about the data that Louis Bont said will be available a year from now. So I went into early this month, and I went into clinicaltrials.gov to take a look and see, in terms of RSV prophylaxis, what was out there. So this is kind of a different view from the slide that Tony Piedra showed a few moments ago. And only looking at prophylaxis, and only looking at pediatric studies. Having started with a query just about RSV in general, and narrowing down to which studies are currently open, not recruiting, or recruiting, and which studies are active but still not recruiting, I was able to identify 39 studies. And impressively, out of the 39 studies, we have 36 different sponsors. And we still see a lot of early studies that hopefully will progress through the pipeline. And the first indication that I get from this is that this field is going to be very crowded, very, very crowded in the future. And if we look at the more late studies that are already ongoing, what we have here in this table, we have GSK's observational study, which is looking throughout the whole spectrum of disease, as one would naturally think, in terms of an observational study. Then we have Novavax study that Allison just presented. It's an impressive study that is enrolling in 4 years 8,000 subjects. So imagine that the 8,000 newborns that are going to come out of these studies will not be available for vaccination or immunization studies in early infancy because they have been already immunized. Parallel to that, we do have the two large pivotal studies, a Regeneron study that's currently ongoing, and MedImmune 8897 study that's about to begin. All of these studies remain, as we were talking, using lower respiratory tract infection as a primary endpoint. And in terms of secondary endpoint, well, Regeneron's already looking at a composite endpoint, looking at medically attended but not lower respiratory tract infection in terms of the outcomes. And I believe that MedImmune is looking at hospitalization without necessarily having lower respiratory tract infection as a secondary endpoint. It's curious to note that in Novavax maternal immunization study, they will be looking at wheezing during the first year of life of children. So it's very curious because it talks back to our previous discussion and slides. So another way to see development in general is that there's a lot of focus. So if you imagine that these are all medically attended acute respiratory illnesses, we're mainly focusing our development looking at, and if we think the first polyvizumab pivotal trial was looking only at hospitalization, then we progress towards looking also at outpatient lower respiratory tract infection. Of course, there are some hospitalizations that don't necessarily have the severity of disease, and that's one of the arguments why hospitalization was questioned if it was the ideal endpoint. But we still have here a big circle of outpatient, medically attended respiratory illnesses that do represent burden of disease, but that are not being addressed in the clinical programs as we speak. And of course, the size of these circles don't necessarily represent the epidemiology. So just bear in mind, it's just a schematic idea, knowing that the many variables that we speak about will change the sizes of these circles. And again, any acute respiratory infection sitting outside of this circle, which it has been our focus so far. But Caroline Hall and many others more time ago were already discussing the importance of outpatient RSV disease in terms of burden of disease, and not only looking at the pediatric or the early pediatric spectrum of the first year of life, but even beyond that. So this is something that comes in terms of the epidemiology and understanding it's there, we continue to see the importance of this burden of disease. A more recent publication from Simpson this year, again, reproduces what we have seen in the past, which is the burden of RSV disease is higher than influenza. Caroline Hall already spoke about that in her publication in 2009. And it's the most important medically attended respiratory infection amongst children up to 5, 6 years of age. And in this specific paper, Simpson shows us that there's not much difference even in terms of the burden of MARI between 6 and 11 months and going towards the second year of life. I thought a lot about if I should insert this slide in this presentation or not, because what I don't want the audience to have the impression is that I'm leaning towards talking about universal immunization against RSV up to 6 years of age. That's not the idea of the slide. But having come from the influenza field and thinking how the evolution of recommendation and burden of disease, that the understanding of burden of disease occurred throughout the years, it's very interesting to see that what's written here about the burden of influenza overlaps exactly what we talk about in terms of the burden of RSV. And thinking about how is it that the burden of RSV is seen to be even greater than of influenza, it makes us think, what will the future bring us? So perhaps we'll never be talking about immunization up to 5 years of age, but certainly we can think about universal immunization to a certain age in early infancy, 12 months of life, 24 months of life. And it's very interesting to see how the progression of the recommendation from influenza occurred throughout the years. So as I approach my final considerations, I was just thinking of bringing this concept. Now I currently work in an organization that deals with passive immunization with monoclonal antibodies. And as the second generation of these monoclonal antibodies appear with longer half-lives, with higher potency, one starts to think about a vaccine approach to passive immunization. And together, of course, with the active immunization strategies that are coming, everybody starts to think of what is the target population and what would be the broader coverage that one would think. And as we move forward, we will continue to question how are we going to deal with these endpoints? Are we going to continue focusing in the lower respiratory tract infections? Are we going to expand our understanding? Because it relates back to my first slide where we say, well, besides licensing the vaccine, we really need to measure the health economic impact of the interventions. So it's important that we bear that in mind. But then we go back in thinking about all acute respiratory tract infections. And I would mention two components of the discussions that we had here. One relates to viral interference and viral replacement. So as our programs progress, and as we eliminate or we reduce the burden of RSV, will there be replacement of other viruses? So in the context of our clinical development programs, we need to start thinking, that this was mentioned yesterday, that we need to understand the epidemiology of the other viruses and how do they behave as the epidemiology of RSV changes. And of course, the second aspect relates to other interventions like life-attenuated vaccines. We just saw an excellent presentation, which is, will there be interventions that are going to reduce upper respiratory tract infections? And if this does occur, is there an effect of herd immunity? And if there's an effect in herd immunity, how will this translate into the epidemiology of disease? And that's why I think it's important that we don't discard the possibility of more and more looking at acute respiratory illness in general. One final comment in this slide is, and this was spoken about in the WHO consultation about vaccine development, is that we have to be very careful if we don't change the health-seeking behaviors of subjects as we conduct clinical trials. When we're doing efficacy studies, we want to collect swabs, and we're looking at medically attended endpoints. And in many cases, in these large 150, 200 site studies, we start having investigators ask us, but now I'm seeing a respiratory disease, and is this medically attended or not? Because either the subject is going back to the study sites to collect a swab, and you need to be sure, would this child have gone to a physician if it weren't for the clinical trial? And how are we interpreting this? And in many cases, the child is going to their primary care physician or to an emergency department, and the perception that the parent has about the severity of RSV, is this changing the behavior also of the parent in leading to a medically attended visit that otherwise he would not go to. So it's important that we bear that in mind. So to conclude, I'll just mention that, well, I think we all agree that lower respiratory tract infection will remain as an important endpoint in our clinical trials. As other candidates, more candidates come into later clinical development, we should be thinking of medically attended RSV disease in general, and perhaps, as I said, of all acute respiratory illnesses. We have to be careful about this change in the behavior of parents as we're looking at our studies. And finally, I invite everybody to think about what were the clinical endpoints used in the influenza studies in the past, and what can we learn from that, despite all of the difference that do exist between the diseases. And also, how have influenza guidelines or immunization policies evolved throughout time, and how does this influence our development programs? So I'll stop here, and thank you very much.
Ross Smith, University College London. It's a comment rather than a question. Ruth Karen yesterday challenged us as paediatric pulmonologists to come up with what do we want to prevent in terms of burden of disease. And I often think that when we look at tiny babies and the degree of respiratory distress that they suffer from RSV bronchiolitis and from subsequent wheezy illnesses, that if this condition was happening in adults, we would have found a vaccine a long time ago. So I think we really need to challenge the field to come up with better outcome measures, and I do not feel that it can be medically attended disease, because these kids suffer from recurrent wheezy episodes in the community and at home, and there must be some technological way that we can measure respiratory distress over a long period in these young children.
Thank you.